Okay. Share screen. All right, we're good to go.
Okay. You introduce yourself. Okay. Thank you. And how do I go to the next slide? Do I use this or do I use this one or this one? This one, right?
Yeah, that one should work. Hopefully. Yeah.
Which way do I go? Oh, it's just.
There we go. So use like the right click.
Right.
Go ahead and click. That up there. Go back to the. Oops, I'm in the wrong one. I'm sorry. There we go. So when you look at over, just click that right there, or you can click your regular mouse arrows.
So thank you for coming for this talk. I'm Dr. Sujatha Nallapareddy. I'm one of the hematologist oncologists. I'm with Rocky Mountain Cancer Centers. I did my fellowship at University of Colorado over here. And then I joined RMCC. So they asked me to do this talk and I thought I would help them out. So I don't have any disclosures. I don't have any financial conflicts or anything. And at the end of today, the main thing is like, our goals are to define the short-term and long-term goals of anticoagulation for venous thromboembolism and what's the length of the therapy and to manage anticoagulation around the procedures and special situations like surgeries and things like that. Okay, so we'll start with the case. So Allison, 49-year-old female who presents with unilateral leg pain and swelling 4 days after completing a flight. And this is the most common presentation we see. I don't know if you guys work in emergency room or not, or a primary care's office. Patients come in. That's the most common symptom. We see swelling, pain in the legs. They recently had a procedure or had a long flight journey. So she comes over and her vitals are like her heart rate is 86 and her blood pressure is normal. Her arterial oxygen saturation, which we always check when we see patients who present with with leg pain, is make sure they don't have any clots in the lungs. So they always check for heart rate, for tachycardia, the blood pressure if it's low, or if the oxygen saturation is low on low med. That triggers us to do more than just do an ultrasound or a D-dimer for these patients. So this is how she presents, and our first thing is like, okay, does she have a blood clot? So what are the criteria for, and there is a criteria for DVT when you see a patient, okay, and based on this criteria, you can stratify the patient to high risk, moderate risk, and low risk. And the high risk is more than 3 points, with all of them having, especially with cancer patients, bedridden for more than 3 days. And that's the main reason why in the hospitals, we try to do quality management studies for thromboembolism with like compression stockings, the SCDs, are they getting prophylaxis or not? And that's, I think it's a marked thing for nurses, for physicians, everyone, when they come to the inpatient setting, they have to mark it if they are getting this or not. It's mainly because if they are bedridden for more than 3 days, they get a high risk for thromboembolism. And also like vein tenderness, leg swelling, edema, and also especially if patients have like superficial veins, like varicose veins and everything, we need to be a little bit more careful with that. So we give them the points, and the points are like, if they are more than 3 points, they are high risk, 1 to 2 is moderate risk, and 0 is low risk. In our patient, she has like leg swelling, she has pain, and she just had the travel. So she comes under moderate risk for us because she got only 2 points on our thing. So how do, if you calculate the risk, and if you see if a patient is high risk, then you definitely go ahead and order the ultrasound for the patient, Doppler ultrasound, which is the confirmatory testing. If you are like having low suspicion, then sometimes in the emergency rooms and the primary care physicians, they start with D-dimer testing, which is a blood test which we do for the patients. And if the D-dimer is very high, then that prompts them to get the ultrasound, because D-dimer is a very sensitive test. If it's positive, it rules out a blood clot. If it's negative, it doesn't mean anything. And if it's low risk, then you look for other causes. Then also then, okay, the patient got diagnosed with DVT. Okay, does this patient need anything other than the blood thinner? So do you need like IVC placement? Do you need thrombolysis? So what do we do like to look at it? So the IVC is the inferior vena cava filter, which we place in certain situations. The main situations we do is like if a patient is actively bleeding or cannot be put on blood thinner and there is a contraindication for blood thinner, that's the first indication we do the IVC filter. And also when patient is going to get thrombolysis, if the vein is completely blocked and if we think the patient needs thrombolysis, then it's always better to get an IVC filter to protect the clot from going to the lung, because they're going to go and break up the clot, and that's high risk. And previously they used to have only like permanent IVC filters, but nowadays we don't do permanent filters. They are all temporary filters and they get removed within 3 months. So that's the one thing we need to look to in the hospitals when patients come in and say they have the IVC filter. Is it less than 3 months? Do they need to get that out, or is it a permanent filter? The permanent filters are mainly for patients who have recurrent DVTs and PEs in the leg. Then we keep, because they definitely need lifelong anticoagulation, sometimes it's better for them to have a permanent IVC filter. We don't want too long if they are not on anticoagulation, because IVC filter itself acts as a foreign body and you can form clots around that. Okay, so that's one thing we always need to look up. And then it's the thrombolysis. So what are the indications for thrombolysis for the patients? If there is like tissue compromise, like if the patient has like compartmental syndrome, like picture where the leg is dusky, painful, the whole leg is swollen, then I think the first thing is to call interventional radiology to get them to see and see if the patient can get thrombolysis ASAP to prevent the limb. Sometimes just getting the patients on IV heparin is not enough, because heparin does help in clot lysis, but it's not as good enough if you have if you are having a threatened compromise of the leg. And also it also helps to prevent like post-thrombotic syndrome, because sometimes if you don't do thrombolysis and if there is an extensive clot, patients have post-thrombolysis syndrome where they have like constant pain, swelling in the legs. And if you get beyond the time, sometimes it gets hard to do thrombolysis later. Once the clot stabilizes, then they have to do it. Then the procedure gets hard for the IR doctors to do the procedure. And then, okay, what lab testing do we do in the ER or in the clinic? So we do CBC to make sure they are not anemic before we start them on anticoagulation, and also comprehensive metabolic panel with kidney function and liver function tests to base on the anticoagulation, because Coumadin is safe for even like liver failure or kidney failure, but like you can't do Lovenox if a patient has kidney failure. You can't do certain drugs, and with the newer anticoagulants, we need to be very careful with the kidney function. So we always get a baseline CBC, CMP for these patients, and also a baseline PT INR to make sure these patients don't have any liver problems with high PT, PTTs, where it would be hard for us to monitor them later. So this patient came to us. Does she need to go to the hospital? So the thing is, previously all the patients who had DVTs were admitted to the hospital and treated in an inpatient setting. But nowadays we are getting more to an outpatient diagnosis and treatment, where patients are even treated from the clinic itself, where if we are comfortable monitoring the patients, or even from the emergency room, we are able to treat them as outpatient. And even the guidelines, like from 2016, support outpatient treatment if you have a good ability to follow up, social support, pain management, and if the patient you think is good, that they will follow up. So does our patient have a PE in our place? So for PE too, you get like a Wells criteria for PE as we have for DVT. If you have more than 4 points, PE is likely, and you consider diagnostic testing for the imaging with CT angiogram. Or if a patient can't get IV dye because of the kidney function, then we do VQ scan for these patients, where you get high probability, low probability, and intermediate probability. And if they are high and intermediate probability, we treat those patients for PE, and if they are low probability, we say patient is very low risk. If it's 4 or less, you consider D-dimer to rule out a PE again. So what are the symptoms? Clinical signs and symptoms of DVT itself, you get 3 points. PE is number 1 diagnosis of equally likely diagnosis. If you have tachycardia, immobilization at least 3 days, or surgery in the last 4 days, you get 1.5 points. And previously diagnosed PE or DVT, you get 1.5 points. Hemoptysis, because of the infarction in the lung, you get a point. And malignancy with treatment within 6 months or palliative is 1 point. So cancer always plays an important role and gets a point too. So also they say that if you think she has a PE, you have a number of appeals for slightly different reasons too. For diagnosis, it's mainly the clinical probabilities, the patient symptomatic too. You use a Wells score. D-dimer testing that is negative is a very sensitive for ruling out PE. And then ultimately a CT angiogram, you do it. And also once you have a patient diagnosed with PE, for you to prognosticate if the patient needs to be admitted, need follow-up more, the first thing after you do a CT angiogram is a 2D echocardiogram of the heart, because we always call it as cardiopulmonary, because the pulmonary affects the heart too, and you can have right heart strain with a big PE. And so you always get an echocardiogram to make sure that the heart function is not very compromised. And if you think if it's a big PE and if there is a compromise in the heart, sometimes you will consider thrombolysis even in the PE for pulmonary thrombolysis too. And you also have the PC score. We don't use it that often, but you do have if you want calculation for the pulmonary severity index. If you have low risk or high risk, you have classes. Class 1 with this points. If you have less than 65 points, it's 1. Class 2 is these are under the low risk, and class 5 is very high risk for these patients. And if you have a high score, then it means the patient needs to be admitted to the hospital and monitored in a supervised setting to make sure they are getting, before you get discharged, that their symptoms are managed, and you can make sure all this come down to lower class before you discharge the patients. So, and the thing is, low risk PE and DVT both may be treated outpatient of the hospital. And what the studies have shown, pooled analysis of more than 12,000 patients with acute low risk PE who were treated in outpatient setting. This was the data. What they found, the recurrent thromboembolism risk is 1.2, it's less than 2%, and fatal PE is less than 0.5% if you calculate the risk and if you're comfortable treating the patients and as outpatient. And even the major bleeding risk is less than 1%, and overall mortality is less than 2%. So we can comfortably treat the patients at outpatient setting if they are at low risk. So you can treat PEs also at home when you have low risk. The low risk being the patients don't have hypoxia, if the blood pressure is good, no recent bleeding, no severe chest pain, the platelet count is reasonable, and they don't have any of the liver or kidney functions. And if you think the patient has good social support and ready access to medical care, and you can treat the patients as outpatient too at home. And what are the ways, now that we diagnose that the patient has a DVT, what are the options the patient has? Do we start with heparin with overlap with warfarin, or heparin for 5 days and then start the newer anticoagulants, which are called NOACs, which have been just approved in the last 5 years. And then we also have we can directly start the patient on the newer anticoagulants. We'll talk more about that. So previously, if you had a patient in 1990s and early 2000s, all the patients were started on heparin with overlap for warfarin, and now we have, with the newer anticoagulants, we don't even need heparin for a couple of them. So traditional treatment plan for most patients was prescribed 5 to 7 days of injectable anticoagulant, which would be heparin in the hospital, or low molecular weight, which is like Lovenox or fondaparinux or Lovenox, fondaparinux, and the new those would be the injectable with then. And then you also overlap with warfarin. The reason we try to overlap with warfarin is because warfarin makes the blood more thicker and then thicker. So it makes blood more hypercoagulable and then gets it to a therapeutic level. So that's why we always overlap with injectable anticoagulant before warfarin gets its effect. And then we need to follow these patients for INR monitorings. With the newer anticoagulants, we have 4 of them. The first one is the rivaroxaban or Xarelto. The second one is dabigatran or Pradaxa. And the third one is Eliquis. And the fourth one is edoxaban or Cevisa. So the first one, Xarelto, if you look at it, that's the most one which we tend to hear. The most common anticoagulants which we use for DVTs and PEs are the first and the third one. The first one is the Xarelto, and the second one is Eliquis, followed by Pradaxa and edoxaban. With rivaroxaban or Xarelto, how we do is you don't need any parental heparin for these patients. You can directly start them. And the way we start is we start with Xarelto 15 milligram POBID for 3 weeks, and then you put the patient on 20 milligram daily. And this got approved in November of 2012. And since then, we've been using this. Eliquis is also same. You don't need any parental heparin for this. The third one, or Apaxaban, the loading dose is 10 milligram BID for 7 days, and then you go to 5 milligram BID with that. But the other two, the Pradaxa and Cevisa, those are the ones which you need a little bit of low molecular weight heparin overlap for 5 days before you start them. So that's why I think we are getting more Xarelto, and Eliquis has been more popular than using Pradaxa and Cevisa, because we don't need any pre-Lovenox for those 2 drugs.
So is there a greater amount of bleeding with those?
What we have seen, compared to Coumadin, there is no greater risk of bleeding. The only thing among these 4 agents, Pradaxa has slightly little bit higher risk of bleeding compared to the other 3 agents. But not compared to Coumadin, not any greater risk.
Are there reversal agents for those other 3 I know, Xarelto?
We'll talk about that.
Okay.
It's coming. Okay. So what are the reasons why you don't want to treat acute PE or DVT with the newer agents? Is if you have severe renal insufficiency. If the creatinine clearance is less than 30, they say you need to be very cautious. The drug which we can use comfortably would be Eliquis or Apaxaban, which, if you look at the package insert, they have guidelines for creatinine clearance, and they say in the package insert it would be even safe to use in hemodialysis patients, the Eliquis or Apaxaban. That's the only drug which I feel a little bit comfortable using in renal patients compared to the other 3 drugs. And if you have a very obese patient or very thin patient, there are no guidelines because we don't adjust the drugs as like Coumadin. We adjust them based on the PT INR. But for these newer agents, since we don't have any monitoring, they say you need to be cautious when you're using these drugs in obese patients and make sure they're okay. And if you have a TPA contemplated, we should wait till the patients are safe before we get them on it. And the other thing is these medications are expensive. So we need to make sure the patients get covered with them. The drug companies have been good, like they are giving some copay cards for patients where they are able to afford the drug. So that has helped us in using these newer agents too. And the other thing is there is no reversal agent yet, except for Pradaxa. Pradaxa has a reversal agent, but not for Eliquis and Xarelto. They say it's in the fast approval phase with FDA, but it's not approved. And also the data is not very good in patients who have like cancer patients and antiphospholipid syndrome patients who are at high risk for recurrent DVTs. The data is less, but like now we are getting a little bit more data where I feel a little bit comfortable using in cancer patients or Eliquis too. So the reversal agents you were asking, as I said, the only reversal agent we have is for Pradaxa or dabigatran, which is Praxbind, which has been approved. For the other two, like the factor 10A inhibitors, the Xarelto or Eliquis, it's still in the approval phase, but I keep asking the drug reps to when, but I haven't seen it approved. There was an article even in NEGM that it does look like it's going to work, so we are just waiting for the approval. And I think once we get that, patients and the physicians would feel more comfortable using these drugs, because now if a patient presents with bleeding, our only options would be to give like a protamine complex in the hospital and then use FFPs and cryoprecipitate, depending on how the patients are bleeding. So that's why these drugs are not very popular in elderly patients, especially who are about 75 years of age, who we think have high risk of falls and bleeding. We are still not comfortable using these agents unless we have the reversal agents. And as I said, Pradaxa, the main, we could use dabigatran or Pradaxa, but it's very expensive, especially for our elderly patients who have Medicare and Medicaid. They can't afford this. I have tried and have a very hard time. I hope once they lower the prices, that would be much affordable. Okay, so just like a quick update, like what are the mechanisms of action and if you can compare these drugs. So if you look at warfarin, it works by acting on factors 2, 7, 9, and 10. Pradaxa is the only one which acts on thrombin. It's a thrombin inhibitor. But the other ones, Xarelto, Eliquis, and Savisa, they all act on factor 10A, which is also similar to Lovenox. Lovenox also is a factor 10A inhibitor. So what I was told is they're waiting to get this, to see if this reversal agent would work even on Lovenox. So that's why they're delaying the reversal agent too. And if you look at the half-life, for warfarin, the half-life is like 40 hours. So we would need like vitamin, it takes like 2 to 3 days to get out of the system for the INRs to drop down when you stop the warfarin. But for the other ones, it's not that bad. Like since these are daily doses, Pradaxa, it's only 14 hours, and Xarelto, it's only like 12 hours, and even Eliquis and all the others are 12 hours. So that's why when you need to stop these drugs for procedures and stuff, it's very convenient. Coumadin, even for a minor dental procedure, you have to stop it at least 3 days before. But these drugs, even 24 hours before, just stopping the drug would be good enough, and you can just start it the day after the procedure for this. But for Coumadin, the main thing is you have to stop 3 days before, and then if it's a major procedure, you have to start them back with Lovenox and again get the Coumadin therapeutic. The Pradaxa and Eliquis, it's twice a day dosing compared to Xarelto and Savisa, which is just once a day dosing. And as I said, the assays for warfarin, we have PT-INR, but the anti-10A activity, even though it works as a 10A, it's not very accurate to monitor for the patients. And we won't get the levels immediately. It takes at least like a day, at least 2 to 3 days for us to get those levels, but that's not the recommended assay for these newer agents. If you're if your patient is having a lot of issues, then you can try it, but that's not the way we monitor the patient, because it's a blood draw every week if you have to monitor the anti-10A levels. So in summary, how do we assess the risk with the scores we have and the high clinical suspicion, and first assess the bleeding risk for the patient and the comfortability to treat as outpatient, and then how to choose the regimen. Okay, so her original, if you look at our previous patient, her original clot was provoked by travel, and we have prescribed Xarelto for this patient, and she has been on Xarelto for 2 months. And then she asked, okay, how long I need to be on Xarelto? Is it 3 months, 6 months, or lifelong anticoagulation? So if you look at the duration of anticoagulation for acute treatment, in terms of long-term treatment, anticoagulation up to 3 months is the recommended dose for DVTs and PEs if it's a first event. If you have like high-risk patients, then you extend to indefinite treatment. So who are these high-risk patients who need like indefinite treatment or lifelong treatment for anticoagulation? So if it's these are the risk factors we look up to see if the patient needs long-term or not. So if it's a provoked blood clot, provoked blood clot, I'll tell you what are the provoked conditions, or unprovoked blood clot. Unprovoked blood clot, we call it as idiopathic, and that's the most common causes of clots. We see 90% of the times we don't have any provocating factors for the patients, and we don't know why they develop the blood clots. And because one second. And then, so what are the factors which we say provoke blood clots? If the patient is post-surgery, if a patient is on estrogen therapy, either as hormone replacement therapy after menopause or birth control pills when they are young. Pregnancy itself is a hypercoagulable condition, and especially leg injuries like fractures, or if they had any procedures. Even arthroscopies sometimes can trigger blood clots in some patients, and if they have flights for more than 8 hours, those are the provocating factors. So if you have these provocating factors, then you don't need more workup, additional testing for these patients, and you can feel okay stopping the patients after 3 months of blood thinners for these patients. If it's an unprovoked blood clot, where we don't know what the cause, the patient just presents without any of those above risk factors. So unprovoked blood clots do poor compared to patients who have a provoked, and especially males are at higher risk for recurrence than females when they have a unprovoked blood clot. And these are the patients who need a workup, and especially if they have any family history too, they qualify more. And also if you have more than one time blood clot, that also increases the risk, and you want to do a hypercoag workup for these patients. So what are the hypercoag conditions we test for these patients? So they are both acquired and inherited conditions where we test for these patients. And is acute clot time the best? No. When you have acute clot, not all the tests are accurate. The inherited factors, you can test for them, but acquired conditions and stuff, they can get screwed up, the results, when you test them in acute conditions. So the tests which are okay would be factor V Leiden mutation, prothrombin gene mutation, and homocysteine levels, because those are mutations. They would be either positive or negative, so those should be okay to test acutely. But like for antiphospholipid syndrome, protein C, protein S, and antithrombin 3 levels, you don't want to test them when they have an acute clot. So you test them when you're ready for the patients to get off the blood thinner, or when they are stabilized more on the blood thinners, then you can test those patients. These are the most common causes of acquired and congenital causes of thrombophilias. If you look at the acquired causes, one would be like post-op state or immobilization, which we talked about, estrogen, cancer. Main thing in the acquired condition would be the antiphospholipid antibodies. The other thing about the antiphospholipid antibodies is, like, if you have them one time positive, it's not positive. You would have to repeat them 3 months apart, and if they are positive, then you consider them to have antiphospholipid positive. The other one was like paroxysmal nocturnal hemoglobinuria, which is a very rare condition, which we tend to see this mostly in very young patients. If they are like clotting with no other reason, we test for PNH for those patients. The other one is JAK2 mutation, which is positive in like polycythemia vera or essential thrombocytosis, where the patients have high hematocrit and high platelets due to bone marrow problem. We test for JAK2 mutation because they are at high risk for forming blood clots. And if you look at the congenital conditions, it's like factor V Leiden mutation, prothrombin gene mutation, protein C, S, antithrombin, and also hyperhomocystinemia, and also elevated coagulation factors like factor VIII. If you have high levels, you can have increased risk for clotting. And the other less common conditions would be like dysfibrinogenemia, dysplasminogenemia, which we don't routinely test. They are very, very rare causes also for blood clotting. So Antiphospholipid testing is probably the most appropriate condition which we test for patients with unprovoked DVT in the acquired conditions. If it is inherited, if especially with the family history, we do more comprehensive testing with all the workup we said before. And and also if a patient has a second DVT or so, then it's more appropriate to test these patients. And also if young females who are planning for pregnancy, it also helps us to say if they are at increased risk for miscarriages during pregnancy and if they need to be on anticoagulation for the duration of pregnancy. So most of the patients, if they are very young and planning for pregnancy, we definitely have them tested for the hypercoag workup. So main other thing we also want to make sure if the patients are getting age-appropriate cancer screening, because as I said, malignancy ranks #1 in also increasing the risk for DVT. So colonoscopies, PSAs, mammograms for these patients, and review of systems is also important, as well as the testing for these patients. And also we always need to discuss the risk-benefit of extended anticoagulation. If a patient has a high risk, what's the risk-benefit? So always that's going to be my long visit with the patients when they are coming for a visit after the hypercoag workup. Okay, what's the risk of being on lifelong anticoagulation versus coming off? If you're on lifelong anticoagulation, you decrease the risk of DVT. What's the risk otherwise is the bleeding risk. That's the main risk we worry about in patients like to being on lifelong. As a hematologist, I feel the clot risk is much worse than the bleeding risk. We can stop the bleeding once we have reversal agents with the newer anticoagulants too. It would be easier for us to stop the bleeding. It's mainly the clot. If they have an acute saddle embolus or a saddle PE, it can take their life too. So if a patient is high risk, I prefer them to be on lifelong anticoagulation. And I can tell them, like, they can always stop it if they have high concerns, like if they are having any issues like in affordability or anything, they can always stop it. And then I tell them to go on baby aspirin for these patients. Aspirin does protect a little bit, not as much as a real anticoagulation, but aspirin. And I also make them aware of the signs and symptoms of blood clot. If they have any leg swelling, pain in the leg, chest tightness, shortness of breath, hemoptysis, the factors which we looked up, they need to get immediate evaluation. And if they have any procedures or surgeries, they need to tell their physicians who are going to do the surgery so that they can put them on extended prophylaxis post-surgery. Like sometimes for just arthroscopies and stuff, they don't do any prophylaxis. And even for hip surgeries and knee surgeries, some orthopedicians just put patients on baby aspirin. But if they have a history of DVT, it's better for them to put on Xarelto or Coumadin for 2 to 4 weeks, depending on how long they are immobile, these patients. And if a patient is high risk and is off the anticoagulation and doing a long travel, sometimes I even put these patients on Lovenox injections, like the day of the travel and the day after the travel, to decrease the risk of DVT for these patients. So those would be the things I discuss with the patient, the risk, if they are willing to be on the lifelong anticoagulation, and if they want to come off, what are the things they need to keep watching for, and how they can approach us or their primary care if they have any signs and symptoms of thrombosis. So especially patients who are at high risk for anticoagulation for a long time would be males, unprovoked DVT, previous history of DVT, and also PE, especially if they have a big PE like a saddle embolus or anything, then that would help us say maybe they are high risk. And also if they have poor cardiopulmonary reserve and have low risk of bleeding, it's better for those patients to be on more than long-term anticoagulation. This was the same thing before discontinuing. Test your patients for antiphospholipid syndrome if it's a young patient unprovoked DVT. And just like perioperative, and so we know how to treat the patients, the duration, and sometimes the patient is like, okay, our patient who has been on our care now presents with like acute gallbladder attack. So should she get the surgery done or should she wait? Because she's only 2.5 months since the last DVT. What's the best time for patients to get DVT surgeries for DVTs when they have it? The reason why we worry about any procedures after DVTs is once you have a DVT, for 3 to 6 months after a DVT, your blood is more hypercoagulable and you're at high risk for forming recurrent DVTs. And especially if you have to get a procedures like cholecystectomy or any big surgeries, then you have to stop the blood thinner for at least a couple days before the surgery or after the surgery, and that would be at increased risk for thromboembolism, and especially surgery itself being a thrombophilic condition, it increases the risk. So that's why we always worry when patients have to get surgeries. If it's an acute surgery and needed, it's needed. So how to decide about surgery timing? So first see what's the risk of recurrent DVT and what's the procedure. Is it a low risk procedure or is it a high risk procedure? And do you need to bridge these patients? And so it all depends on everything. It depends on the procedure, renal function, what medication the patient is on. So what are the risks for DVT? So if the high risk is if a patient has severe thrombophilia like factor V lead mutation or any mutations or anything, or if they recently had a DVT within less than 3 months. Moderate risk is 3 to 12 months and no hypercoagulable conditions and active cancer and recurrent DVT. Low risk is if it's more than 12 months. So usually for surgeries, 12 weeks is a cutoff. After 12 weeks, patients are safe to go ahead with the surgery. If it's below 12 weeks, which our patient is because she's only 10 weeks, so those patients are high risk and we try to bridge those patients with anticoagulation if they really need surgeries. So what's Allison's bleeding risk? So as I said, these are the risk procedures which they give us in the guidelines for thromboembolism. The low risk are minor dental procedures like root canals or tooth pullings, and derm procedures like freezings or like removals and cataract surgeries. For low risk bleeding surgeries, you really don't need bridging for this patient. You can just stop the Coumadin like 2 to 3 days before and they can just get back on after the procedure. Or even with the newer blood thinners, you can just stop them the day 24 hours before the procedures and then can restart the day after the procedures. But if the high risk surgeries are like any urologic surgeries, pacemaker, if they have large bowel colon polyps which need to be removed, or if it's extensive tissue injury which can be with like pericardial, intracerebral, epidural, they say cholecystectomy, it's like hysterectomy and cholecystectomy are considered low risk, but you need to be considered very carefully for those two procedures because it's hard. Like sometimes if a patient is high risk, which is very obese, if they had recent blood clot and everything, I tend to bridge them still. I don't consider them like low risk. So it will be just depending on when the surgery, what are the other risk factors for patients. So those are the two surgeries like hysterectomy and cholecystectomy. They put them under low risk category, but you need to be careful. And so how do you bridge? So based on the half-life. So basically for Coumadin, the half-life is 40 hours. So you stop the anticoagulation like if you look at the bridging procedures for high risk, you stop the Coumadin 5 days before the procedure, start them on Lovenox, and stop the Lovenox like 12 hours before the procedure. And then start back on Lovenox and Coumadin the day after the procedure. That's the standard for warfarin. But for all these other agents, you really don't need bridging. You can just stop them 24 to 48 hours. 48 hours I do if they have like any spinal procedures or anything. But if it's like normal procedures, I just stop the drug like 24 hours. They just don't take the day before the procedure and they just get started after the day after the procedure on these newer agents. So that's easy thing with the newer agents. We don't need to worry about Lovenox bridging for this patient. So many procedures, so if in summary, many procedures can be performed safely without any interruption, but we need more data to select patients and procedures. And for patients whose procedures require interruption like 24 to 48 hours is enough if they have sufficient renal function. I don't think this is nothing. Yeah. So that's how we manage these patients. So I can take any questions if you want.
What else, possibility of register in patients with Coumadin versus serotonin?
So for like if a patient had it who are already on those and they present with a stroke, yeah, we definitely need to stop them if they have a bleeding. And that's the patients where we need to decide if they what's their risk, like how much they need these anticoagulation. In patients who have intracranial hemorrhage, most of the time, if it's a severe hemorrhage, we stop the anticoagulation, reverse the these agents with FFPs, vitamin K and everything, and then we reassess. If the patient really needs anticoagulation, we try to do IVC filter for these patients, and we can see if the patients can just be on baby aspirin, if that's enough. And then if once the bleeding stops, then you can reevaluate again and see what's the risk benefit, how much they need the anticoagulation, and assess that way.
Because the newer regulation they cause
Bleeding? Not really. Only thing was they saw a little bit more with Pradaxa when they were using dabigatran or Pradaxa, when they were using that in patients, elderly patients especially, they saw intracranial hemorrhage, but not stroke, not hemorrhagic stroke. Yeah.
You see these commercials on TV.
At the end, they mention everything. Yeah, because it's mainly with elderly patients. They could be at high risk for bleeding. That's how it can happen. That's why I said you need to be very careful in elderly patients. You need to monitor their renal function and assess their risk of faults before you really put them on these. So if an 85-year-old comes to me, I am very careful. I don't prefer to put them on the newer agents. I try to put them on the older agents, unless it's a good 85-year-old who is active, less risk of falls, no good kidney function. Then I'm okay with starting those patients on the newer agents. But if a patient is coming with a walker, borderline renal function, I don't prefer them to be on the newer agents. Atrial fibrillation, I defer it to the cardiologist based on they have a CHAD score. So now I see them use more with the cardiologists nowadays, but I think it's the same situation with DVT or AFib. They have to assess the risk of bleeding versus strokes for those patients, and they have to be careful. And we used to see quite a bit of patients who got who were on AFib, were put on Pradaxa or Xarelto, admitted to the hospital with bleeding, and we get consults. Okay, what do we do now? This patient has a bleed. Now it's getting better. I think we all are getting more experience with these newer agents, and cardiologists are being very careful in who they put to. So we used to get those patients and we were like, okay, we don't have a reversal agent. We would give them protamine complexes and blood products and monitor those patients. Yeah.
So in some ways, the newer agents are still kind of in the lab.
Yeah, I think those are good for younger patients. Like if it's a 40-year-old who comes in, who doesn't like to come to the clinic to monitor every day the INR, who wants to eat salads, who doesn't like to be off the greens. And those are good candidates for those agents. We are using more of those agents.
There's not the diet restrictions either.
Newer agents, that's the main thing they like no diet restriction. Even though they don't have the reversal agents, they are still comfortable because they can eat whatever they want and they don't have to come to the clinic to monitor. So they feel comfortable using them. Yeah. Yeah, thank you. Yeah, sure. Yeah. Get you. This is mine.
This one, the simple save?
Yeah.
Usually if you drag it to the trash, it'll eject it.
I thought there would be something over here. Sometimes I just remove it. I just want to make sure if there is any eject button, or I can just remove it.
I don't.
No? Okay, I can. Oh, here.
Safely remove. There we go.
Okay.
Boom.
Yeah, no. Sometimes if I do it, I have issues with your things.